to meet you.
Really nice to meet you too.
Yeah. So tell me about yourself. You grew up in Queens?
Yes and no. So I was in Queens for about 5 years. I did most of my childhood in New Jersey, basically middle school and high school. But then I found my way back to the city in terms of undergrad, grad school, and I still work there now. So very near and dear. And I don't live in New York anymore. I'm in Jersey City. But I think New York is still such an amazing, incredible place, both for not just for healthcare, which is what I find so fascinating about it. It's a place for the arts, for finance, for entrepreneurship. You can meet literally any kind of person in New York and make them a part of your friend group or a part of your network.
True. I think, as you mentioned, the things, Queens, New Jersey City. I lived in Jersey City for the longest time. I don't know, but I had a long love affair with NYU. So I went.
Yeah, I saw on your website.
Yeah. Where did you go to college? At NYU or somewhere else?
I went to NYU for undergrad and for grad.
Yeah. As I read parts of your book, it just hit me hard because and not all doctors can say this. I think those of us who trained at Bellevue, and then I went on to work in the Lower East Side at a time when it wasn't as swanky necessarily as it is now. Yeah, I have definitely seen the disparities of health when it comes to different populations, and having struggled with those kind of issues as a physician. So now the way it inspires me is that I focus a lot on women's health.
Right.
But with that, right, and you talk about this in your book, there's a lot of stuff, right, that women are at a disadvantage about, especially minority women or ethnic women. And so I was hoping that we could really focus our podcast on that, on women and women's health and the disparities of healthcare that we have to experience. I can only assume that you have, because when it comes to my patients, almost every single woman patient that I have that I've spoken with has experienced some kind of disadvantage. You have to wonder what's going on, right? And up until I would say my early 30s, right, I was blessed and I didn't have to necessarily experience that. I definitely experienced racism, systemic racism and racism in a variety of colors.
Of course.
But when it came to disparities of health, I didn't necessarily experience it until certain health issues started coming up for me. And then it hit me smack in the face and it left me feeling like, what was that?
Yeah. No,
I'm a doctor. Having the background and the education to fend for myself definitely allows me to speak in a way where I can make myself heard. But I always wonder, what about that person who doesn't have that vocabulary and doesn't have that understanding and maybe isn't as courageous enough to do?
Hey everyone, big shout out to Ariel Vivleka, founder of Finally All Natural. Ariel is on a mission to educate people about hidden ingredients in skincare products. Did you know the FDA allows incidental ingredients that aren't labeled or disclosed? That's why Finally All Natural is special. They focus on how ingredients are created, excluding extracts and essential oils, and have world-first formulas that work for a variety of skin types. They've also partnered with CleanHub for eco-friendly packaging and offer an exclusive organic face oil that has been scientifically proven to boost the proteins in your skin, enhancing hydration and strengthening the skin barrier. All 100% vegan. If you're into holistic skincare or non-toxic living, Ariel is your go-to expert. Keep up the amazing work, Ariel. Get in touch with her today. All the links are in description below.
I wanted to understand what inspired you to go into this field, and then understand why the book. Why did you write this book, Healthcare in 1,000 Flights? And why did you title it that?
Yeah. So actually, if I can work backwards, I think the title is really interesting. So I was working with a developmental editor at the time, just trying to work on high level ideas for what I wanted to cover in the book. And broadly speaking, I knew I wanted to tell the story of the people of the United States, very similar to Howard Zinn's A People's History of the United States, but really focus it on a healthcare angle. And this was around the time where COVID was really picking up. This was around February, March 2020, which I don't need to tell you or any of your listeners was a really crazy time to be in healthcare, especially in the New York, New Jersey area. And so my developmental editor, who is also an emergency physician, was talking about his experience providing care to patients and how for a lot of patients, they experience the healthcare of 1,000 slights, where it may not be overt and direct racism like what you mentioned, but just the assumptions that are made about them based on how they're dressed or how they're speaking or what insurance or lack of insurance they might have results in a different experience of care for those patients. And so in my mind, I was thinking about the fact that so many of us experience marginalized identities. So many of us experience multiple marginalized identities at the same time. And so we've all had some experience with experiencing healthcare of 1,000 slights. So that's really where the title came from. It came from that conversation with my developmental editor, especially as he was giving me his insights as far as providing care in the emergency room at such a critical time. And then in terms of my interest in the field and how I got interested in this, I've always been really passionate about history. I think we all know that history tragically repeats itself, as we've seen in the past couple of election cycles. But at the same time, it's really important to understand how we got here, right? I think a lot of people, especially when COVID started rearing its head, had a lot of questions about the healthcare system. Why is it designed the way that it is? Why is it that certain people aren't getting proper access or access to high quality care or affordable care or whatever the case is? And so for me, I was really interested in that through line of like, how did this system get built? Who was it built for? Who was it built by? And how has that had everlasting impacts centuries or generations later?
I want to take a moment to give a huge shout out to Melissa Murphy-Pavone and her amazing team at Mindful Financial Partners. Melissa has over 18 years of experience as a certified financial planner and divorce financial analyst. And what truly sets her apart is how she values people over portfolios. Whether you're going through major life changes or just want to take control of your financial future, Melissa's approach is all about aligning your wealth with the life you truly want to live. She doesn't just focus on growing wealth, but also on creating balance and purpose in your financial journey. You can get in touch with her at her website, mindfulfinancialpartners.com, and you can find all the links in the description. Be sure to check it out.
And so what I realized was I was in grad school at the time that I started writing the book, and I realized that those of us in healthcare, we have a very high level understanding of how the system was designed, but we don't necessarily think about healthcare as a system that interacts with other systems, right? Nobody experiences health in a vacuum. We experience our healthcare in the context of our access to public transit, to green space, to quality education, to a safe place to live. Like, we all live our lives in very intersectional ways and ways that interact with these systems in different ways. And so I was really passionate about bringing those three pieces together, which were history, policy, and all of these different aspects of quality of life. Ultimately, when we talk about populations getting healthier, we're really not just talking about health, right? We're also talking about how do we improve their quality of life. And health is just one factor through which a person's quality of life can be improved. So that's how I got really interested and passionate in the topic. And why the book? I just wanted to bring these different pieces together. And I actually started writing the book on the suggestion of a Georgetown professor who ran a book writing program, who reached out to me on LinkedIn and said, hey, you post really interesting content. Would you be interested in joining this program? And I think that was a sign to me that my thoughts and ideas that were just vaguely being posted on LinkedIn could actually form a coherent narrative that people would be interested in, especially given COVID and everything else that's been happening in the healthcare space.
Oh, definitely. As a doctor, as an internist who really zones in on women's health, there are all sorts of questions that I always form, right? Why hasn't research been done in this area?
Right.
When I went to medical school and I graduated, I can't even keep count, but many years ago, we were 50% women and 50% men. So by now, you would think that we would be well represented in certain fields. And from what I understand, we're still underrepresented in medical fields. And you have to wonder why and what the discrepancy is and why there's certain things that have affected us. And I talk a lot about hormones and women's health and the Women's Health Initiative. And a lot of doctors, even back then, and those were my fellow residents, we would be referring to the Women's Health Initiative. And we, even at that time, and this was a couple of decades ago, where we knew that there were some issues with that trial. However, when that trial came out, it was like everything came to a stop. Women got taken off their hormones. And for 2 or 3 decades after that, it remained the same. Nothing changed. And it was a big injustice that was done. There were no real major trials that happened after that. And no one really, even up until now, no one really stepped up to the mic and said, hey, there were some real issues with that trial. We need to really look at that and examine that and figure out whether we need to practice that way or not. But it just continued, where women were not prescribed hormones.
Are you a woman with big financial dreams but no idea how to reach them? You'll love working with Dr. Annie Cole, a money coach who's on a mission to help women earn more, build wealth, and retire early. In her 20s, Annie was a burnt-out social worker, struggling on a $26,000 salary. By her 30s, she had climbed the ladder to a vice president role, invested over $350,000, owned $1 million in real estate, and cut 20 years off of her retirement date. She now runs her own coaching business, Money Essentials for Women, and inspires women to step into new levels of money mastery and confidence. Ready to see how Annie can help you? Set up a free financial consultation at www.money-essential.com/coaching. While you're exploring her services, grab a copy of her new book, 101 Ways to Build Wealth, at money-essentials.com/book.
So these are always questions that I have. Why the discrepancy? What has happened to the field of medicine when it comes to women?
That's such an important question. And I think the way that you framed the question was from 2 different perspectives, right? One was lack of female representation in clinical leadership. I think to your point, I've definitely seen a lot of female doctors, female interns, residents, attendings who are just starting out. There's lots of those, but there aren't necessarily as many women represented in either clinical or administrative leadership positions. And that, I think, has been a global problem for a very long time. And that just has, I think there are lots of factors that play into that. But I think primarily one of the challenges is that I think people are still uncomfortable talking about women in the workplace in relation to women in their families as well. And it goes back to, we're not just what we are in the hospital or what we are in the workplace. We're also people who belong to other communities, other groups. We have other responsibilities. What is ironic is that men also belong to these other groups and families and other responsibilities, but that's not necessarily considered as central to their identity as perhaps it is for women. And that might not be the case for everyone, but there are certain assumptions that are made with women. There are concerns around women. If you hire too many women of childbearing age, is that something you have to be concerned about from a staffing perspective? So I think a lot of those limitations continue to be in place and really are a barrier to promoting women to more senior positions in clinical institutions. But I think on the flip side, just trying to understand why, for example, the Women's Health Initiative that you mentioned, I think that, again, it goes back to the question of who is the system designed for and who is it designed by? And I think what we're increasingly realizing is that the medical system is almost obsessed with women as childbearers, as if they have no other identity. And we know not all women want to give birth, not all women do give birth, but that's the primary way in which our society thinks about women. And so that's why women weren't allowed to be part of clinical trials for a really long time. That's why women are often gaslit when they want to do tubal ligation at a young age. And they know for a fact that they don't want to have children, but people are often trying to convince them, oh, you might change your mind when you're older, etc. But I think this real obsession with women primarily as childbearers before anything else has really limited what the medical system is able to do for women as far as research, as far as clinical trials, as far as actual clinical care is concerned.
You think that it is changing now? Do you see that change happening?
Absolutely. I think challenge is that this kind of change is going to continue to be really gradual. It's been interesting too to watch other conversations about women happening at the same time. So obviously we're seeing increasing investments in women's research, particularly through the Biden administration. We've seen a lot more focus on women's health in the startup space, with folks focusing not just on reproductive health or gynecologic health, but also on women's health as a separate field. For example, women have different microbiomes compared to men. So how do we actually make sure that they receive the correct care as a result of that? Or for women who are experiencing chronic conditions and present differently from men, or not even just chronic conditions, even things like heart attacks, right? As you well know, heart attacks may not always present in women the same way as they do in men, but that's not always widely taught in medical schools. So I think those conversations are very gradually shifting at the same time as conversations about women's roles in society. There's been so much more conversation about the mental load, the work that women do to run households that is often invisibilized, not paid, and often taken for granted, whether or not those women are in the workforce or not. And so I think a lot of these conversations about women are happening in parallel. So it's been exciting to see that transition. But unfortunately, I think it's still going to take us a really long time to get to the point where we see more women in roles of clinical leadership, as well as more investment and understanding of women's bodies and how women react to drugs and things like that.
In your book, you mention what happened with George Floyd and how did it shape your ideas of the inequalities that come when it comes to race and health and just everything in terms of equity, right? But how did it form your opinions and in terms of access to health?
Yeah, absolutely. I think what happened with George Floyd is just a very sobering reminder of how inequity is experienced by people in different ways. So somebody like George Floyd had probably experienced health inequity, but unfortunately, the inequity that he faced in the context of police brutality is what ultimately ended his life. So I think it's a good reminder of how we all are interacting with different systems at the same time, and how inequity that shows up in one particular system can very easily show up in other systems as well. And one of those big challenges, like you mentioned in your question, is access. So when we're talking about access to health, it's really important to also think about how if you don't have access to other things, you also can't access health, right? If you are somebody who lives in a major urban center like a New York City, if you don't have access to public transit, that's going to limit your ability to get to a doctor's appointment, let alone schedule the doctor's appointment. If you're in a place where you're on Medicaid and a lot of the doctors that you're interested in seeing don't take Medicaid, that's another form of a barrier to access. So it's interesting to think about, again, us as human beings interacting with all of these different systems. And if we have access to some systems, that might allow us access to others. But what's very clear is that when you don't have access to certain systems, it can really limit not just your access to health, but also your access to quality health, to affordable health, to all of the things that people need to do to maintain their health, right? I think we talk about access to health usually from the context of can you get an appointment? But before you even get to that appointment, can you get access to childcare so that someone can watch your kid while you go to that appointment? Can you even get something scheduled based on your insurance or lack of insurance? So there are all of these other factors that really play a role in your ability to access health, which is access to all of these other services and systems.
And it's very good that you point these things out, because those of us who are fortunate enough to have those things, we don't really think about it. We take it for granted. We have health insurance and we have someone else to take care of our child, and we don't have to worry about how to take care of the copay or how to even get to the appointment. But these are all things that I have witnessed as a young physician when I was working at Gouverneur Hospital, where I had patients who struggled with those things. And thankfully, Gouverneur did have at that time, I can't speak for now, have systems in place to help those people so that they could access. But it doesn't really make up for So when you don't have, as you were mentioning, access to certain things, you likely don't have access to fresh fruits and vegetables, right? Which happens to always be more expensive than anything that comes in a package or in a can. And having lived in New York City for God knows how long, I used to ride the subways and I would see kids drinking their Coca-Colas in the morning with their Snickers bar for breakfast. And you have to wonder, right, what's happening with their blood sugars and what it puts them at risk for as they get older. These are things that we take for granted because as the whole socioeconomic status, it makes a big difference. And I can tell you, I grew up in a middle-class kind of family, but having entered the world of medicine, it completely opened my eyes to things that I didn't have access to in terms of information, in terms of, so many things that even to this day, I think about how, and I'm fortunate and I feel totally blessed from it, how many things I have access to that my parents didn't have because they came from a different country. They emigrated from India and yeah, they had their community, but it's different when you're at a different socioeconomic status. So I think that kind of was one of the reasons why I chose to work in a community center. I always wondered, why did I opt to do that where a lot of people didn't? And I think those were one of the reasons. And I think it inspires me to help women now because I, as a person, not as a doctor, and we were chatting about this offline, where I've experienced inequalities. And when it first happened, it just threw me off because at that time, and this was several years ago, I didn't necessarily go in saying, "Oh, I'm Dr. Mandel." I went in a humble, okay, I'm just going to go in and not necessarily use my title. And I have experienced things where it totally threw me off. And then I quickly learned that I had to announce that I'm a physician in order to level the care.
Yeah.
You shouldn't have to, but I've learned by my experience. What made you decide to enter this field? What was it, something that happened in your own life that made you decide that this is where I'm going to be heading?
Yes and no. So for me, when we moved as a family to the United States when I was 5. So I still remember not living here and then getting here. And I think for us, we actually had a fairly positive experience with the healthcare system when we got here. And that was partially because we had an Indian community to rely on, ask who are the best doctors or who are the most rather culturally competent doctors who won't laugh at us if we say that we're going to give our kids turmeric milk if they're not feeling well. We were able to identify who those people were and have fairly positive, affordable experiences with the healthcare system. But as I got older, I realized that's not the case for a lot of other immigrants. That's not the case for a lot of other people. And from a policy perspective, and around the time I was in college, it was really when Obamacare, or the Affordable Care Act, I should say, was passed with the idea that we really need to be expanding coverage to all different types of people, not limiting coverage based on pre-existing conditions, et cetera, et cetera. And it was around that time when the Republican Party was pushing back against the Affordable Care Act and trying to institute repeal and replace. And it was around that time where I was like, what are they repealing? What would they replace it with? What would that system look like if this actually succeeded? And that really forced me to look more closely into how is our system actually set up, and it's set up in very interesting patchwork ways where if you're above 65, you get coverage. If you're below a certain income level, you get coverage. But if you're neither of those things and don't have an employer that sponsors your health insurance, what happens to you? So I started to really ask those questions of myself. If I was an American living here with this kind of job, would I have health insurance? Or if I had pre-existing conditions and lived here, would I have health insurance? And that really motivated me to go into healthcare administration to see if there was a way in which I could be part of the solution and part of the story of actually improving access to care.
You're definitely a voice that I want to continue hearing. So you're welcome to come back on my podcast at any time and or collaborate on any future projects together.
Yeah, absolutely. That would be so much fun.
Yeah. All right. This was great. I'm so glad that we had a chance to meet and talk. And yeah, have a great weekend.
You too. Take care.
Bye.